So we've touched on a little bit of LDN. We're going to dive into it a little bit. So it's literally an old drug. It's been out since 1964. Well, we use it in really large doses. We can use it for alcohol overuse syndrome, methadone addiction, and a wide variety of other addictions. We started really digging into its effects with low doses in 1985. Again, not new information. Dr. Bahari was working with a wide variety of AIDS patients. Most of these were men back in New York who were also alcoholics. So they did not necessarily contract AIDS or HIV through drug use or needle use. This was through sexual activity. And so that area, that grouping of individuals were treated differently because a lot of them were also alcoholics. Dr. Bahari was using naltrexone, but because most of them were out of work, they were cutting their tablets up to kind of stretch using that medication. And when he literally watched quite a few of these individuals get better instead of getting worse. So back in the late 80s, if you were diagnosed with HIV, that was a death sentence. You were literally going to be dead in a couple of years. But between the work of Dr. Bahari and Dr. Zagon, they literally found that the use of low-dose naltrexone improved the outlook of HIV and AIDS diagnosis because of how it modulates the immune system. So anytime that we're dealing with an autoimmune issue, we can see that low-dose naltrexone will upregulate natural painkillers, also called endorphins. It will block very specific opiate receptors. It can also block the turnover of certain cancer cell growth factories in the cells. And we also know that when we're dealing specifically with dermatology issues, it will block those receptors that actually cause itching and irritation. All the while it's modulating the immune system. Pretty cool drug. Because it's working directly at the cellular level, specifically on these cells, and we know the direct mechanism of action with this, and these different toll-like receptors are found in the cell and also outside of the cell, we know that it will very effectively work on a wide variety of disease states. So sometimes when you hear about a medication that's going to work for anxiety and depression, also works on cancer, helps to decrease situations of autoimmune inflammation, but also works on psoriasis and works on eczema, you're kind of like, what the hell kind of snake oil is this? I mean, we've heard those stories before where, my gosh, you put it in the water, it's going to help everybody. And that causes a lot of red flags, especially when a lot of us rely on good science in order to understand and even recommend medications. We need to know effectively how that's going to work. We need to scientifically prove that this medication is going to work and not cause a lot of harm. So there was a physician who said, look, we know that low-dose naltrexone is working in a wide variety of issues. I'm really tired of reading all of these articles. I'm going to put together a summary of that. So he did, and he was working at Dartmouth. So we call it the Dartmouth study. So he did this back in 2016, I believe it was. And he compiled 900 articles and case studies and summarized those into disease states, looked at the process by which that study used, looked at the dosing that it was used in that study, as well as the outcomes. And when he looked at the outcomes of those, he summarized how many people participated, how many people dropped out for whatever reason, and why did they drop out? What other comorbidities or what other disease states did they have? But since 2016, 2017, we've seen even more published papers on the benefits of low-dose naltrexone, but we see very few side effects, and we also see very few drug interactions. So if you would like a copy of this study, I'm more than happy to email that to you. Actually, I should stop right there. Scarlett would be more than happy to email that to you. She is the master of that. So when we're dealing with evidence-based medicine, we need to really look at the very specific drugs, because not all drugs work in all different situations. But we have very effectively used LDN in psoriasis to not only decrease inflammation, but also the cell turnover and the itching. Eczema, Haley disease is it's a very painful medication. So earlier somebody asked about pemphigoid. So Haley looks similar to that. It's usually in the armpit area. It can be raised, warm, purple. It can have pustules. It can have raised plaques. And because it's in the armpit, it's very difficult to wear clothing. We use low-dose naltrexone in alopecia, not just alopecia areata, but we can use it even in combination with other medications to help decrease inflammation around the hair shaft. So pruritus is itching. We can see it used in lichen situations, because lichen sometimes is an environmental issue. It can be a gut issue. It can also be an autoimmune. But we use it for a wide variety of other autoimmune issues too. Everything from fibromyalgia, multiple sclerosis, Hashimoto, Graves' disease, and also in addictions. So if you're not asking yourself, how can one drug do all of this? You should be asking yourself, because when I first learned about low-dose naltrexone about 20 years ago, I thought, there is no way. I mean, come on, really? But the more I got into the science of it, yeah, it really does. When we use it in higher doses, we find that this medication works very, very differently than when we use it in very small doses. And we've even seen studies done in 2007 where it was combined with medications to help decrease opiate addiction. Now, unfortunately, that medication never made it to the forefront and into the general public. But because of the information that was published in that study, and that was done at Yale, I believe, we can use low-dose naltrexone in its ultra-low dose, microgram dosing, and we use it simultaneously to help individuals get off of using their opiates and pain medications. Oral doses are about 96% absorbed, which makes it very, very effective. It's not always available. It doesn't have to be available just in a capsule. We use this in liquids as well. We can also use it in a troche or a little lozenge that can be dissolved underneath the tongue. We do use it transdermally because we use it for autism and individuals on the spectrum disorder. We use this in young children. Dr. McCandless was an amazing researcher. Unfortunately, she's no longer with us, but in the information that she presented and put together using this medication in very young children, is as young as 10 or 11 months old, she saw dramatic results. Children that were not using eye contact, they were not using their words, they would flap, they would literally flap. They stopped doing that after a very short period of time. And one of the most poignant stories that she told when I listened to one of her interviews is that there is something very special about when a parent tells you that their child is 3 years old and for the very first time said, "Mommy, I love you." That hits you hard, right? So, you know, I'm a mom. I've got 4 kids. They're all grown. I've got grandchildren now, which is the best. But I can't imagine not hearing your children's words and not hearing from your child that they love you. That's just amazing. But we do know that LDN works not only topically, but also transdermally. So naltrexone actually blocks toll-like receptor, specifically receptor 4. We know that it also blocks toll-like receptor 9, which is some of the newer information that has come out in the last 2 to 3 years. And it also blocks interleukin 6 and 12. So you probably heard a little bit about interleukin 6 over the last 15 months or so with the COVID crisis. So it's one of those cytokines that invades the lung tissue. There's a lot of fluid that builds up, a lot of inflammation that builds up. And with that can cause a lot of damage in the lungs, and sometimes it's long-term. But we do know that LDN will block that dramatically. We know
Michelle,
that
we
it
have
will also,
a question.
yes,
Sorry. We have
no,
a question
please.
regarding that. Someone asked, do you have a statement about COVID, specifically immunity response, other than the vaccine?
So to clarify, are you asking if there are other medications that can be used to prevent getting COVID, or once you've got COVID can help decrease the symptoms? What, can I ask a little more specific?
You can, whoever asked that question, if you'd like to stay anonymous, you can just type it into me and I'll say it, or you can feel free to unmute yourself and just speak out.
I'm not shy about these things, by the way.
I haven't seen anything. Maybe they're typing, so we'll just give it a second.
So I'll go over a little bit more information and maybe this will help. So because LDN actually suppresses these inflammatory markers, we see that it has been very effective in a wide variety of situations. I do know that there were 3 studies specifically looking at LDN in positive COVID cases. There was 1 in New York and 2 in Chicago. Because what was interesting is that early on, a great number of individuals who were taking LDN were not catching COVID. And there was curious as to why. And I don't know if that, I kind of lost the track of that study, that one little study that was being done in New York. However, low-dose naltrexone was being used in the treatment of positive COVID cases to decrease the inflammatory storm, and those individuals got better sooner. But but LDN wasn't the only medication that was being used, right? So there were different arms of those studies, in the 2 in Chicago and the 1 in New York. And some of them were using, there was one study they were using ivermectin. There was another study that was using some of the other commonly used medications. Zinc was usually a part of the study. But I haven't seen the full studies published yet. I believe they are coming. When I spoke with one of the physicians that was working in the same hospital where they were conducting one of the studies in Chicago, she said that they were looking to publish those findings more toward the end of summer, early part of fall. Any more details on that question, Scarlett?
The only other details we got were, do we even need to be concerned about COVID?
Do we need to be concerned about COVID? Yeah, absolutely. COVID is a real thing. It's not a myth. It's not a super flu bug. It's a bug all into itself. It's a virus that we have seen dramatic issues with. It affects people differently because everybody's immune system is at a different stage. So whether you vaccinate or not, I think that this is a good reminder to make sure that you are enhancing or modulating your immune system as best that you can. Because whether we're dealing with COVID or flu or, whatever virus is floating around, viruses can be detrimental to people's health at a variety of time. You might think that you're super healthy, that you eat really well, but that doesn't mean that a virus can't gobsmack you and really lay you out. If you want to avoid most of those types of infections, make sure that your immune system is as healthy as possible. How can you do that? You can do that by avoiding sugar, avoiding simple carbs, eating gluten-free, making sure that your vitamin status is as potent as possible. That doesn't mean you go out and you take a whole bunch of medications. It means that you get some micronutrient testing and see where you're at. Make sure that your gut is super healthy. Again, you can test and see where you're at. Making sure that your hormones are modulated and optimized, because when your hormones, especially estrogen, progesterone, testosterone, DHEA, and more specifically cortisol and insulin, if those are optimal, whether they're up where they should be or down where they should be, you will be as healthy as possible. Avoiding stress, that's not easy to do. Getting really good sleep, those are all really important factors to making sure that you have a very strong immune system. And that's the bottom line. So whatever you do, it doesn't really matter what we're faced with. If your immune system isn't in really good shape, you're not going to be in very good shape. I hope that answers that. If not, keep typing. We're good. Atopic dermatitis is rooted in inflammation, as is so many other situations. And anytime that we can decrease the amount of inflammation, specifically on the surface level, we can make sure that we are as healthy as possible. The bottom line is skin is the very largest organ in your entire body. If your gut is not working well, you will see issues land on your skin. Just because even regular metabolites of eating food and those food breakdowns, whether they are environmental elements or not, will escape the gut, go through the bloodstream, and end up in the skin, because the skin is very very vascular. This is a study. It was, again, a placebo-controlled double-blind. It was a small study, but I will tell you, most drugs that are out there were done with really small studies. They weren't done with hundreds of thousands of people. They were done with small numbers. This was done back in 2009. And this was on the efficacy of oral naltrexone on itching and atopic eczema. I'm wondering if I have my slide in here. So there was a woman who was a single mom, office worker, couple of kids at home, and she had eczema primarily on her hands, and she had a lot of skin peeling, and it would break and crack and peel. And because she typed on a computer almost all day long, the agility of her fingers were very important, and being able to, open and close her hands, pick up the phone, reach for a pen, change papers. A lot of that was causing some issues, because when she had eczema on her hands, this would peel and flake and crack and bleed, and it would dramatically affect her job. So eventually she had to quit. So she used oral naltrexone, and within 60 days, it resolved. And she was able to go back to work, which was fabulous, because she was a single mom. She needed to be able to support her family. We know that low-dose naltrexone is an alternative treatment. It's not necessarily a treatment that we use all by itself, but we can use it by itself. It is a wonderful place to start. This was 71 patients. That's a lot. Only one with psoriatic arthritis, but you can see here that it actually worked quite well for individuals. Now, this was a recent study that was done last year. So even though most of us were home, and well, I wasn't home, but a lot of people were kind of closed up, that doesn't mean that science stopped. It meant science just kept right on going. This was psoriasis vulgaris, which means that it had more pustules and it was larger in plaques. And this was a 6-year-old woman who had 10% of her body surface area covered in psoriasis, in these painful, raised, itchy plaques. It also affected her joints. She used low-dose naltrexone and was able to see complete remission, 6 months. Most of these people have gone through years and years, if not decades, and many, many physicians to realize that using low-dose naltrexone is even an option. So they've used topicals, they've used orals, some of them have even used biologics, and they're not seeing the resolution that they want, so they keep moving on. They keep asking more and more people. This was a wonderful study that was done last year. Dr. Leonard Weinstock, Dr. Jill Cattell are two individuals who also work specifically in their own private practices, but they are medical professionals that contribute to the LDN Research Trust in using, and this study specifically was looking at mast cell activity. Dr. Weinstock is a gastroenterologist, and he uses LDN specifically for Crohn's and ulcerative colitis, but he also noticed that those individuals a lot of time had skin issues. So he then kind of branched out, because really a GI specialist is looking at skin on the inside of the body, and a dermatologist looks at skin on the outside of the body. So those two areas do tend to overlap. Again, these were a couple of studies, again, very recently, that showed dramatic changes and results. This was a study on lichen and how the evidence of decreasing the itching and the inflammation, specifically on those using low-dose naltrexone, were able to tolerate that without adverse side effects. Hailey disease, again, very, very horrible autoimmune, fairly rare, but again, they were started at a fairly low dose and increased up to 4.5 milligram, but not all of them did. Again, only 3 patients, but they did see a significant healing of their issues and their irritations and lesions. And again, once they stopped the LDN, their symptoms came back. And that's because when you stop the blockade of those inflammatory chemicals, you put a stop to it. You basically put up a fence with low-dose naltrexone. You remove the fence, and they're just going to run amok again. So that was on Hailey with the benign pemphigus that someone mentioned earlier. So we do see low-dose naltrexone being used continuously, and we're seeing more and more studies being done on very significant and serious diagnoses. Alopecia areata is one that nobody really wants that diagnosis, and sometimes the hair loss is in blotches. We can use LDN in combination with other medications, whether they're topical or oral. But a lot of times we have seen evidence where not only is the hair shaft regrowing, and it's because of the reduction of inflammation in that bulb, right where the hair grows. How low-dose naltrexone is prescribed is we start low and we go slow, because one size does not fit all. We don't necessarily jump right in at 3 and 4.5 milligram. We usually start very low, maybe even a 0.5 or a 1 milligram. We use that daily at bedtime, and we slowly increase over very specific intervals, usually 7 to 14 days. In some situations, adding a morning dose can be beneficial. The morning dose and the bedtime dose are not necessarily equal. Usually we'll ramp up the bedtime dose to anywhere between 3 and 4.5 milligram before starting the morning dose. And we do this for depression and anxiety, as well as a wide variety of pain situations. So those are very easily changed with time. Forms are available. We have a wide variety of templates available for physicians to use, and there's quite a bit of information at the pharmacy, both in book form as well as paper format. So we have a lot of research materials, but there are 2 books, the LDN book, volume 1 and volume 2, that have those chapters are written specifically by experts in those fields. Most of those are physicians and researchers. When we're able to find someone's happy dose, it's with the slow titration. And so in this titration schedule, if somebody gets up to week 3, they're taking 3 milligrams, whereas and they might feel really good, but maybe on the next week they move up to 3.5 milligrams and they're not feeling as great. Then we literally put them back down at the 3 milligram because more isn't necessarily better. Some people do better with liquids than capsules, and that's okay. Liquids are easier to manipulate and maybe even more slowly increase those doses, so we can fine tune those doses. And we had to do that with several patients where they started with this titration schedule and we had to move them to this titration schedule. So we moved them away from capsules to liquids because one gal's dose, her favorite dose is 3.1 milligram. And you can't do that by opening a capsule and splitting it up. Not going to happen. It doesn't work. So whether they're tablets, we don't make tablets currently. We make very small capsules. They're very easy to swallow. We do quality assurance on every single batch. Not all compounders do. When we're dealing with very small doses of 1 to 4.5 milligram, it's really important to make sure that that quality assurance is being done to ensure that those doses are precise. Colorants can be added, although most of us don't use that. And 90-day supply is always going to get you a better price. These medications usually range in price from around $60 to $77 for anywhere from 2 to 3 months supply. That's pretty affordable. We will work directly with you to help you decide what base and what dosage form is going to work best. I will say that the Naltrexone is bitter. So if we're using a liquid, we tend to put a little splash of stevia in there. That is negotiable. It does not have to be in there. And we always add a little bit of flavor. We're no longer using tea berry. Tea berry is a very old flavor. Some people really like the nostalgia of that. Unfortunately, it's not currently available. There is another flavor that's really yummy, though. It's called mango passion fruit. It's kind of fun. We can use this in a wide variety of dilutions and also applications. So whether it's topical, going to sit on top of the skin, or transdermal, get deeper into the skin and into the bloodstream, will depend on what type of diagnoses that we're trying to treat. So if we're treating somebody with autism, we're going to use transdermal. If we're using this for psoriasis or a lichen, we're going to use a topical format. We don't use very much of this. We're using 0.5 to 1%, so very small amount, and it plays well with others. So we can combine it very easily to reduce redness, enhance better skin turnover, more effective turnover. We can use anti-infectives, and we can also use it to help stimulate hair growth. So transdermal is usually used for those individuals who are looking to send that right into the bloodstream, but yet they could not use an oral liquid or capsule. We also combine it with other medications to enhance mood and depression, and also brain fog and burnout. We're very careful to make sure that we set up expectations ahead of time so that patients understand that LDN is not a cure-all. When you stop using LDN, your symptoms are probably going to come back. Most respond within 60 days. However, some feel worse before they feel better, and that's because of how the immune system is actually modulating. So for example, if you have 10 issues, the immune system is going to work 24/7 equally on those 10 issues. It doesn't pick 1 or 2 or 5 to work on. It's going to work equally. So it's going to take those 10 issues and give each one 10% of its activity. However, as certain situations resolve, concentrated efforts will be left on those areas that still need some work. So maybe you've reduced your diagnoses by 50%. So you've gone from 10 issues, now you're down to 5 issues. So the immune system is now going to be able to concentrate its efforts on those 5 different areas, which means all areas are going to get 20% of its work. So when the immune system is working harder on a more concentrated area, sometimes other issues arise. And those can be underlying diagnoses that maybe were not apparent to begin with. So that's where sometimes people feel worse before they get better. But we check in with people to make sure that people are doing well, make sure that they're not attaching so-called side effects or new things that are coming up directly to the LDN, and we can make sure that LDN is working as effectively as possible. Not everybody gets to the same dose. Some people's happy dose is somewhere in between. So when we follow up with patients, we're able to hear amazing success stories and a few failures here and there. That does happen. We're all a little bit different. And sometimes we're able to change doses to make things even more beneficial for that individual. Dosage adjustments usually happen maybe as many as 9 to 12 times before we're finding the right dose. And that's where the liquids are a little bit easier to manipulate, but sometimes capsules can be dosed appropriately. We answer questions as they come up. We help to alleviate side effects, which there are very, very few of. Maybe vivid dreams, that just tells us that LDN's working. Some people might have a little bit of a headache. They might get a little bit of constipation because of how it blinds to some of the receptors in the gut, but we're able to alleviate that by decreasing dosing. We always communicate back to the prescriber to enhance overall patient outcomes. That's the bottom line, right? We're here to help you make you feel better. We're on your journey with you side by side. We're here to help answer your questions as best we can. And one thing I love about LDN is that it's really low risk, very few side effects, low cost, low drug interactions, and it's a very low dose. So it's kind of one of those things that's like, why not try it? So I thank you for your time tonight. Boy, we are an hour 49 into this, almost 2 hours in. And boy, I appreciate everybody hanging with us and staying to the bitter end. This does not have to be the very last time we chat. This is my personal email. You're more than welcome to use that. You can also get a hold of me at the store, although I won't be there tomorrow, but I will be back on Monday. You're also more than welcome to check us out at makerscompounding.com. We've got a great website there, as well as the ldnpharmacist.com. I am an international consultant for the LDN Research Trust, and you can find us on a wide variety of social media platforms as well.